Hi everyone, it's Emily Davenport here. I'm going to be starting my presentation today. It's entitled HIV/AIDS in South Africa. So moving right along to the second slide, South Africa is one of the largest countries in sub-Saharan Africa. It has a population of over 54 million people. It borders the countries of Namibia, Botswana, and it also has the country Lesotho and Swaziland within its borders. As a former colony, it has an export-oriented economy. It is the world's largest producer of platinum, gold, and chromium. And even though it has one of the higher GDPs per capita in the African continent, it does have the world's second highest Gini coefficient of 62.5. So the only country that is actually higher than South Africa is Lesotho, which is within its borders, as I mentioned. So this is a country, moving on to slide 3, with a long history of these disparities and inequalities. There's a long history of racial tension, of white settlers oppressing Native Africans. That started when the Dutch colonized South Africa in 1652. There was British and Dutch rule throughout those centuries, and then the unjust system of apartheid was established in 1948. Sorry, that's my cat. Many of the African National Congress top leaders, which was a civil rights organization that worked to dismantle apartheid, were imprisoned for decades, including Nelson Mandela, who was the first democratically elected president of South Africa in 1994. So apartheid didn't end until the mid-90s, and this is really important for us to remember in the context of HIV/AIDS because the outbreak started in the 1980s. So up until, the mid-90s, this was an outbreak occurring amongst people who were literally second-class citizens within their own nation. So that certainly didn't do any favors to the folks who were trying to control this epidemic. So moving on to South African demographics, I have the population pyramid there. And you can see that its wide base is similar to many developing countries. However, it is a little bit different. You'll notice that the widest part of the pyramid is sort of towards the middle. So those are the working age adults. This shows that the total fertility rate has started to decrease in recent years. And as that young population is aging, they're, taking more part in the workplace. The average life expectancy at birth is 63. Like I said, the average age or median age is in your mid-20s. Maternal mortality rate is 138 deaths per 100,000 live births, and infant mortality rate is 32 deaths per 1,000 live births. So that's just to give you some idea of how South Africa stacks up against other African countries and other middle-income countries. So just a quick snapshot of the HIV epidemic as it stands today. So the prevalent is over 19% of the adult population. There's over 7 million people currently living with HIV/AIDS in South Africa today. There were 180,000 deaths due to HIV/AIDS last year, and very sadly, 2 million children have been orphaned as a result of those deaths. And that data is all from the UN. Some background and history into the HIV in South Africa. So the first AIDS cases were identified in 1982. These were 2 cases of male homosexuals who did end up passing away. And they believe that these men actually acquired HIV in the United States. They were both flight attendants who traveled to the United States for work. So even though HIV did originate in Central Africa, it wasn't introduced through Africa. It was introduced through the United States and through travel. The first cases that were transmitted through heterosexual sex started in the late 1980s, and then prevalence just began to increase through the 1990s. So again, remember, like I said, apartheid is still going on until 1994. So the people who may be suffering from HIV/AIDS aren't getting the type of care and treatment that they need. In 2000, there was a really interesting incident of HIV denialism. This idea that HIV did not cause AIDS was really taking root, in part because of the president at the time. South Africa was actually hosting the International AIDS Conference in Durban that year, and the president gave a speech that basically insinuated that AIDS was not caused by HIV, causing a big stir. And as you'll see as I continue this presentation, there has been a big shift since 2000. South Africa has really grown in how it's controlled and treating HIV. So methods of surveillance, because this is a widespread outbreak with high prevalence rates, they test pregnant women to get an idea of prevalence and incidence. And those are at public sector clinics throughout the country in both urban and rural areas. In 2012, the South African National Department of Health, along with other public, private, and academic partners, conducted a really big study called the South African National HIV Prevalence, Incidence, and Behavior Survey. So as the title suggests, the idea was to determine the prevalence and incidence and the risk behaviors associated with HIV transmission throughout South Africa. This was a huge study that was representative of the population. They obtained nearly 40,000 questionnaire responses and almost 30,000 blood specimens from various household clusters in order to get an idea of prevalence and incidence. And moving along to epidemiology and what was found in these studies. So this first figure here just puts in context how South Africa stacks up against other South and Eastern African countries. So you'll see that South Africa doesn't have the highest prevalence rates. The highest prevalence is found in Swaziland and Lesotho, Botswana. In 2000, Botswana's actually made also great strides in the last 15 years. But South Africa still has the largest HIV epidemic in the world, and that's because South Africa is much, much bigger in terms of population than all these other countries. It just blows them out of the water. So even though South Africa's prevalence is lower than some of those other countries, it affects more people. You'll also notice in this figure the trends are generally good. All the countries are on the downward slope from 2000. Prevalence rates are going down. Some by greater measures than others, but it is good news in general. Moving on to the burden of HIV/AIDS in South Africa. So there is a wide disparity between the provinces of this country. So you'll notice that KwaZulu-Natal has the highest prevalence rates in comparison to Western Cape, which has the lowest. You can see in the map on the slide, the red areas are obviously where the higher incidence rates. These areas are also less urban and less developed than Western Cape and some of those green areas, like that's where Cape Town is. And some of these other areas to the right are not nearly as urbanized. And moving on to demographics. So this really ties into some of the risk factors that I'm going to talk about in the next slide. But women are at a much higher risk of acquiring HIV when compared to men. And this is because the main method of transmission is heterosexual sex. And there's a lot of different power dynamics that are a lot of different risk groups that put women at greater risk. For instance, women are more likely to be sex workers, they're more likely to be younger and an age-disparate sexual union. That could make them have less agency when negotiating condom use. But again, you can see across all age groups in this figure that women have higher prevalence rates of HIV, except for when they're 80 or 60 plus, then it's higher for men. So like I mentioned, HIV is most commonly spread through heterosexual sexual intercourse in South Africa. So young black women are at the highest risk of infection. Black women, of course, or black people in general, of course, make up about 80% of the population in South Africa. However, again, so it would make sense that they're at the highest risk for infection. And this young women are at high risk, but there are groups within that that are at an even higher risk, such as drug users, sex workers, and those young women who are in sexual unions with much older men. And men who have sex with men do have higher rates of HIV transmission than the population at large, but still not as much as sex workers. Sex workers do have the highest prevalence rate. So moving on to preventative measures, South Africa has actually had great success in treatment as prevention, so implementing antiretroviral therapy for all HIV positive patients, not just those with a CD4 count above a certain threshold. So over 56% of those who are positive for HIV are currently on ART. So this is really great. South Africa is starting to approach the UN's 90-90-90 goals. It still has a long way to go. But that TASP, so treatment as prevention, in conjunction with programs that are aimed at increasing testing in young women, have been successful. There's been a whole host of initiatives that have been working at increasing education and employment and leadership positions for women as ways for lowering HIV incidence. They even have HIV educators specifically at secondary schools in areas with high prevalence rates. So there are a lot of barriers to controlling HIV in South Africa. There's a lot of obvious ones like extreme poverty. Like I said, that Gini coefficient is really big. So even though there's a lot of wealth in South Africa, there's a lot of extreme poverty. And those who are living in extreme poverty don't have the same access to health care. Women and girls, while there are more education and opportunities than there used to be, there need to be more. And even though there's been a lot of work in destigmatizing HIV, especially with the increased use of ART, there is still a stigma, and that is a big barrier to testing because people don't want to know their HIV status because they don't want to get that diagnosis. And joining with that is a lack of perceived risk. So this was an interesting study I read about among young women, and 30% of the women that they interviewed perceived themselves at little or no risk of acquiring HIV. And those women actually went on to acquire HIV in a few years. So even though they saw themselves as not being at risk for HIV, they still actually did go on to acquire it. So this, poses a challenge for public health officials that they need to keep on educating these high-risk populations so they know what they need to do to protect themselves. And like I mentioned, HIV/AIDS denialism was a big issue, especially when it was coming from national leadership. Overall effectiveness, like I mentioned, has been really, really great. These treatment as prevention programs have prevented millions of infections. They've been aimed at vulnerable populations, including women and sex workers. However, there are room for improvement. So, for instance, the involvement of international donors and global health practitioners has some pros and cons. Some of the pros is that these big international partners who are donating to these programs and helping fund them offer a lot of expertise and can leverage support to other donors and other supporters. The main con, though, is sustainability. So most of South Africa's major successes have been funded in large part by international donors. And what are they going to do if these donors shift their priorities to other health initiatives? So South Africa needs to, as a middle-income country, needs to focus more on domestic funding of these HIV prevention initiatives, and they are taking steps to do that. So just in conclusion, South Africa should continue doing what it's doing in terms of treatment as prevention. However, the public health officials shouldn't become complacent with the success, lest the outbreak and epidemic return with a vengeance. So thank you very much. These are my references. And thank you for watching. Bye, guys.